Hi, my name's Hannah McCarthy. I'm the Chief Behavioural Scientist at Better Points. I'm also a PhD candidate at University College London, where I sit between the Department of Behavioural Change and Health Informatics. I've been invited by ConV2X, thank you very much, to speak to you today about complex behaviour change interventions, particularly in the context of community health and some of the projects that we're working on here in the UK. So before I talk a little bit more about some of the projects we're working on, just to introduce Better Points and who we are. We are a behaviour change technology company. We've been around since 2010, and our primary method of engaging with users, particularly across local authority areas in the UK and municipalities in Europe, is through a user-facing app, which employs gamification, GPS tracking, rewards and messaging to change primarily travel and health behaviours over time. So just to set the scene a little bit about healthcare apps and smartphone usage, you can see here some of the headline stats. 90% of the population of England now have a smartphone, and worldwide that equates to more than 6.5 billion people are using a smartphone. In the UK, 40 million adults are using apps, and there are more than 350,000 health apps in the major app stores. And if you'd like to drill down into these stats a little more, you can see the references are on this screen. So if everybody's using apps and there are so many healthcare apps, why can't we just encourage people to use those apps to manage their own behaviour? And the answer is that technology alone is not a silver bullet. You can see here, I've tried to simplify the kind of intervention that we work with, and we describe that as a complex behaviour change intervention rather than simply a digital behaviour change intervention. Because in order for the intervention to work, it needs to be embedded within the community, and it needs to be constantly promoted through communications. And so just to describe this slide a little bit, because it does have a lot of moving parts. On the right-hand side, you can see a description of our behaviour change platform. And this is what underpins the app that you can see depicted slightly to the left of the screen. And the platform allows us to not only serve up goals and rewards and content to the users, but also to track data. And we do this in a number of different ways. So we employ the GPS tracker from the phone that allows us to evidence behaviours such as physical activity over time. We also use incentivized self-reported surveys and ecological momentary assessment. So that's self-report at the time of the behaviour or as close to it as possible. We also use QR code scanners to evidence behaviours that are less easy to track, and particularly to evidence when somebody's done an activity or arrived at a class and it's in a particular space in a particular time or particular location. So then we use this data to evidence and measure change, but we also use the ability to engage with people directly within the app to assess barriers to change. And I'm going to speak a little bit more about this as we go through the presentation. And so within the platform, we also have a dashboard, which the administrators can use to review the type of behaviour change data over time, and then to segment and target participants and to personalise incentives and content depending upon those segmentations. And all of this is underpinned by behavioural science, as you can see a nod to on the far right of this slide. And if you look to the left of the slide, you can see I've put 3 boxes, which just explains a little bit of how we work with communities in the different locations that we run projects, particularly across the UK. So we engage both with local shops and service providers so that we can give a local flavour to our catalogue, but we also integrate with local events and campaigns that are promoted within the neighbourhoods, but also that we can then mirror within the app and link bonus rewards and boosted incentives to. We can also include local charities and organisations such as local schools, so that participants can donate their points or join together to collectively earn points that they might want to contribute to the local community. And down in the bottom left here, you can see a little bit of information, and I will expand on this, on how we work with health services on the ground. So in the UK, the local authorities work with integrated lifestyle service providers who help support efforts around weight management, smoking cessation, alcohol reduction, and so on. And those are clinics that are actually available to people within communities on the ground. So we work with those health service providers to mirror their 12-week pathways within the programme, within the app, and to link incentives to key milestones along those journeys. So the presentation that I'm going to give today is broken into 3 main parts. First, I'm going to pose some questions for you to ponder whilst you're listening to the case studies that I'm going to describe. I'll outline the learning outcomes that I hope you will gain from some of the information I'm sharing today. And also then, as mentioned, the case studies of some of the projects that we're currently working on. So I've broken the questions into 2 main packages, the first one being around current practice and future impact. And I'd like you to reflect on the current amount of time and budget that you might spend on acute care rather than prevention, and what you're currently doing to avoid the acute care problems of the future. And thirdly, what might addressing poor health behaviours before they develop into acute care issues mean for you, your resources, and the populations that you're currently trying to help. And so more specific questions about measurement and evaluation. How are you currently baselining poor health behaviours in your communities? Are you currently using any kinds of incentives and rewards? And do you think that you could perhaps leverage those further by combining them with digital channels, even at the first step of engaging with communities, before we even get into behaviour change? And how do you currently elicit and measure that change? So there are 3 core learning outcomes. Firstly, to understand how smartphone technology combined with incentives may be used to engage residents in their own self-care in the places that you live. To learn how to use apps to baseline existing behaviour and measure change over time. And thirdly, to gain insights from smartphone-derived data and understand how it can be used to identify barriers to change. So the 2 case studies that I'm going to share with you today are from the London Borough of Hounslow and from Buckinghamshire County Council. And you can see from this map of primarily of England, roughly where they fall in the southeast of the country. So the London Borough of Hounslow Public Health Team commissioned Better Points in July 2021, and the programme was later extended for a further 2 years in July 2022, and so is now ongoing. The original target was for 1,000 participants, which we've now exceeded, and more than 80% of that original target number completed the baseline, so we've got good engagement. The focus of the programme is primarily on inactive residents. There's some focus on smokers, and mostly we're aiming to reach those from more deprived neighbourhoods. And today what I'd like to do is focus on the want to but can't segment. And this group was previously identified from market profile and segmentation work that the London Borough of Hounslow had done with London Sport. And this persona was really what you would imagine. It was a group of people that indicated that they felt they wanted to do more exercise, but somehow they weren't able to do so. And so the work that we were doing was to try and understand more about why that wasn't translating, that intention wasn't translating into action. And before I describe that work in a little more detail, I just wanted to share a broad overview of how we currently work with our system to segment and target different groups of people, depending on their behaviour change needs. And we describe this as a hybrid manual digital cycle because we use the digital tools that we have at our disposal to collect data, to visualize data and understand trends and what's happening in changes of behavior over time. But we use human intelligence to decide where to then draw the lines around segmenting and targeting groups, and to then tailor the incentives and the messaging that those groups see. And this is an iterative cycle whereby once we've targeted those groups, we then assess and evaluate the impact that's had on behaviour, and then we do further segmentation. So going back to the work that we did in Hounslow with the want to but can't, these are two screenshots that show how this data has been collected within the app. And on the left-hand screenshot, you can see in the middle of the second row, the Hounslow Get Started survey. And that's our baseline survey for this programme. And you can see many other surveys in this screenshot, but that's because it's from my phone and I've got lots of programs showing. On the right-hand side, you can see how the survey actually appears in the app. So this is what the user is able to see and go through and respond to. So what we did was we took the answers to this baseline survey questionnaire that was pushed out within the app and was linked to incentives. And we took those users who had answered yes to any of the questions and added them to the want to but can't group. They were offered boosted rewards and extra messaging to encourage them to reach 150 minutes per week. And then we repeated this activity each month to segment new users that had signed up. Then we wanted to understand how many of those users had gone on to achieve the 150 minutes, and so that we could then move them into a maintenance group and not continue to offer them boosted rewards, which of course would eat into our local authority clients' budget. And the way in which we delineated this was we did quite a literature search to understand the current literature on habit formation. And what we found was there's no one particular cutoff or magical point at which people form a habit, but that this can change and varies by individual. So we chose to take the sort of threshold of 6 out of the last 9 weeks of activity, having reached the 150-minute goal. We then, as I mentioned, moved these people into a maintenance group and offered them shopping vouchers as part of a prize draw to help with the cost of living crisis, but also to simultaneously manage and control the budget so that we knew exactly how much it would cost each month. The remaining participants were segmented into 3 groups, which you can see here. Those who were in the want to but can't and also inactive group received the daily bonus and the extended and the extra messaging. The other 2 groups received just the extra messaging only. So what we found from this activity was that about 1/3 of the want to but can't group did actually achieve the 150 minutes of NHS recommended physical activity per week, which of course is great, but it leaves 2/3 of the group who didn't achieve it and didn't change their behaviour. So what we've done is we've gone back to that group and we've asked them, what is it that prevents them from being more active? And you can see some of the preliminary results here on this slide. And what we're going to be doing over the coming months is using this information to even more fine-grainedly target this cohort with specific incentives and messaging and signposting that will help them hopefully move from this inertia to being able to realize the activity gains that they feel they want to achieve. So before moving on to my second case study and talking about Buckinghamshire, I just wanted to share some user stories with you because I think that this really reminds us that all of this data and all of the technology, whilst it's exciting and it's really fascinating to use, all of these data points are actually real people, and real people like Anna, who was really struggling to get out and be more active because she had arthritic knee pain. And so she found she was gaining weight and it was becoming a bit of a downward spiral. And when she started to use the app, being part of a virtual community was something that motivated her. And giving back to that community by donating points to the Hounslow Food Bank was also something that she found really motivated her to get out, helped her to lose some more weight, and had the positive effects on her mental health as well. So this illustrates that it's not just about the financial rewards for the individual. It's about having a whole range of different rewards that can appeal to different people. And indeed, Tamar also found that giving back to her community in the form of donations to the Hounslow Community Food Box was motivating for her. But also Tamar expressed, and it's not on this slide, but expressed how much she loved to swim. And that the incentives and rewards allowed her to be able to take more swimming classes at the Lambton Leisure Centres. And here again is an example of working with key stakeholders within the community in order to offer the kinds of rewards that matter to people. And finally, from the user stories from Hounslow, I wanted to share with you Sam's story, because I think that this illustrates very well how it's important to target multiple different types of behaviour and not just one health behaviour, such as physical inactivity, weight management, or smoking cessation, because different people are ready to engage with these different target behaviours and start their journey towards change at different times. And so in Sam's case, he was able to engage with the app because he could see that it was going to be quite easy for him initially to earn rewards for walking, and then realised that he could also use the app to help him to get to his smoke-free status. So moving on to Buckinghamshire County Council, which was another programme that was commissioned by the public health team in the local authority, and this was in October 2022. It's a 24-month programme, which is still ongoing, obviously. We had a target of 3,000 participants, which we're well on our way to achieving. The focus here is also on inactive and overweight residents from deprived areas. And here too, we've integrated with lifestyle support services. So this is a little bit of a dry slide, but I wanted to use it to explain how we're integrating with the weight management support services in Buckinghamshire. So the user will register on the app, perhaps just because they want to earn a voucher. They will complete the baseline and identify as overweight. And we use that information then to segment them and invite them to sign up for the weight loss services that are available within their community. Hopefully then the participant will sign up with the programme that's provided by the lifestyle service provider and start to attend online sessions. During these sessions, the participant will receive a workbook which they have to complete in order to unlock rewards. And the way in which they do this is by receiving a code on the last page of the workbook, which they can then enter into the Better Points app in order to get their points or prize draw tickets. Once the participant has completed all 12 workbooks, they can receive a bonus reward, and then they get resegmented into a group that are known to have completed the weight management 12-week programme. But we will continue to monitor their weight with in-app surveys and track physical activity via GPS journeys that the participant chooses to record. And then we will use that data to monitor and understand if there are any relapses, if the participant has regained weight or perhaps become inactive. And then we will use that along with the existing GPS data to further segment them and potentially target them with new personalized incentives and messaging. But hopefully we won't need to, because their motivation will have moved from more extrinsic, so valuing an external motivator like a voucher, to a more intrinsic motivation. And I'll talk a little bit more about that in a moment. What we found, the results of this work, was that there was a 44% increase in increased awareness of weight management services. And you can see here that among inactive residents, there were about 22% overall that increased their physical activity, with a group moving from completely inactive, that's less than 30 minutes per week, to doing 150 minutes per week, which is the NHS recommended minutes, and also some who didn't quite reach that, but certainly increased their weekly minutes of physical activity to over 30% and approaching 150. So here's a case study of Pia, who used to drive everywhere, even to the corner shop. And what I like about Pia's story is it's a nice illustration of the kind of extrinsic to intrinsic motivation journey that many of our participants go on, where they begin joining the programme simply to gain a voucher, and then they start to gain an interest in their statistics, in the dashboards within the app. They like to see how far they've gone, they compete with themselves, and over time the behaviour itself becomes self-reinforcing, and the value is intrinsically in feeling healthier, having more energy, and realising that travelling in ways other than car might actually be preferable. So I hope that the information I've shared today throughout the whole presentation has spoken to some of the learning outcomes at the start, but I thought it might be helpful to particularly reference some of the slides that I felt linked to each of the three learning outcomes. And you can see here that the complex behaviour change intervention description on slide 4, which underlines the importance of community, I think speaks to learning outcome 1. We've also spoken about targeting multiple behaviours simultaneously in order to maintain engagement and reach people when they're ready to start on different types of behaviour change journeys. And then, of course, I've shared with you examples of how this has worked in the UK by working with local authorities and the integrated lifestyle service providers. With regards to learning outcome 2, I've touched on the different methods of data collection, and I think that it's important that we use all of the tools available to us and that we link these with incentives in order to get the kind of engagement that we would like to see. So looking at kind of 80+ engagement with surveys rather than smaller percentages that we often see with more traditional marketing approaches. And then finally, with regards to learning outcome 3 and the ability to tackle barriers to change, to understand where people have started, where they've got to, and why they might be struggling to make that change. And you can see that I've referenced slide 12 and 17 to draw your attention back to the cycle that we, the manual digital hybrid approach that we take. So why is any of this of any interest? So what? What are you going to do with all of this information? Well, possible next steps that you might consider include approaching stakeholders in your area to explore how you might be able to share costs and resources to action preventative care when so often the priorities seem to be falling towards acute delivery. Consider an audit of current practices, understand what you're already delivering on the ground, and then ask technology providers how they can integrate with those existing services and not just expect to graft a piece of technology on top of everything that's already happening and for it to work seamlessly. So you might also want to look at building survey tools into existing apps or consider buying a solution to foster the kind of two-way engagement that I've described today, and understand, be able to go back to people and actually ask them about why they're struggling to change, and to ensure that you link incentives to this kind of activity. And then to use the data that you collect through the inbuilt trackers and step counters within apps, combine that with your qualitative data from survey tools to understand how to segment people and personalize the behavior change intervention for them. And then finally, if you followed the steps above, then please do consider asking, as I said, people about barriers to change, creating targeted campaigns, and then seeking further support, perhaps from us, if you feel you need it. And what I'd like to do today is leave you with this quote from the Academy of Medical Royal Colleges. And this was in their report on how to fix the NHS. And what they say is that we need a paradigm shift on health prevention and that everybody recognises that this is a worthwhile investment. But I think that often it's easier said than done. And as I hope I've given you a flavour of today, it is quite a complex behaviour change intervention that you need. And hopefully this presentation has gone some way towards helping you to put that in place. Thank you very much.